Good evening. We are going to go and get this started. I know some people are still signing in. So I'd like to welcome you to the first talk of the Transition Program webinar series. My name is Andrea Craven. I am a nurse practitioner with pediatric and adult congenital cardiology. I may have met some of you. I am one of the coordinators of the Transition Program. Elizabeth Stalder, the other nurse practitioner, will also be joining us. And thank you for coming. We are happy that you are here. As you probably were notified when you signed in, this talk is being recorded and will be posted on the Congenital Heart Center website. The Transition Program also has a tab there if you would like more information about the Transition Program after Dr. Joint's talk. We will be answering questions after Dr. Joint is finished. There is a Q&A tab as a part of the Zoom. So if you would like to put a question in there, we will be monitoring it. And at the end, Elizabeth will be taking over the question and answer portion. Just a little bit about the question and answer. We would like to keep it general, not disease specific or a personal question. Those can be happily addressed in a transition program visit, and that contact information for the program will be given also during this talk and at the end of the program. Everyone is muted and their camera is off as well. So if you want to have a question answered, it does have to go in that Q&A. So we will get started with Dr. Joint's talk. Dr. Michael Joint is a clinical assistant professor of pediatric cardiology and adult congenital cardiology at University of Michigan Health. He is medical director of the University of Michigan Congenital Heart Center Transition Program and cares for children and adults with congenital heart disease at Mott Children's Hospital and the Frankel Cardiovascular Center. Dr. Joint also sees adult congenital cardiology patients in Grand Rapids at Michigan Health West and at the Brighton Center for Specialty Care. Dr. Joint cares for children and adults in both the hospital and outpatient setting. And with no further ado, Dr. Joint, you can take over.
Great. Thank you very much, Andrea, and welcome to everyone who's attending. Tonight, I will hopefully be able to provide some overview and a little bit of guidance about your care with congenital heart disease. So just to give everyone a little bit of an overview of tonight's topics, I wanted to first review what we mean by congenital heart disease and then highlight two of the most important concepts to understand: transition of care versus the transfer of care. We will then discuss some specific questions about transition and finally give an overview of the University of Michigan Heart Center's transition program and ways that you can all connect with us. During the talk, please feel free to submit questions, as we would welcome an open discussion at the end of the presentation. All questions and concerns are encouraged, and I would definitely like to give some time for input related from the rest of our team as well to answer some of those questions. So again, just for a quick review about congenital heart disease, it is the most common congenital defect, and it impacts around 1% of all live births in the United States. Due to significant advances in care over the past 50 years, over 90% of children born with congenital heart disease are now surviving and thriving into adulthood. And due to these amazing medical and surgical advances, there are now actually more adults than children living with congenital heart disease in the United States. Broadly speaking, congenital heart disease is considered to be present if you are born with one or more problems with the structure of your heart, and that has to be present since birth. This can include problems with valves, holes and deformities in the heart, or problems with abnormal heart rhythms. Many patients have had a surgery or procedure due to this heart condition. Some people have had many procedures, and even some have had no procedures. Regardless of your history, though, you all share the common diagnosis of having been born with a heart defect. Some of our patients are bothered with the term disease, as they feel it implies a sickness, but this is really just a descriptive term. Many patients believe that because they have had a surgery, they do not need to worry about their heart. And some people believe that they do not need to follow up with a heart doctor ever again. This is incorrect. Even for patients that have been repaired, it's important to follow up with a cardiologist well into adulthood due to the complications and issues that can arise many years after their procedure. Taking over your care can be quite complicated and something that does not occur suddenly. It's a process and requires education, time, and support. I want to take a moment now to introduce two concepts that are really key to this process of taking over your own medical care. The ideas of transition versus transfer. There's a clear distinction between the transfer of care and the transition of care. Transfer is merely moving from a pediatric to an adult provider. Transition involves the continuing education of patients with regards to their congenital heart disease, the importance of longitudinal care, and leading patients toward a more autonomous or self-care medical model. The key to a successful transition is to recognize the importance of this education and prepare for lifelong self-care. Transition begins early in the pediatric cardiology clinic, a long time prior to the transfer of your care, and it's an ongoing process that continues well after you have transferred your care. It's recommended that starting at around age 12 to 13 years, patients begin the process of transition. Although this seems young to some, the goal is for full preparation well before transfer occurs. A critical aspect of the transition and transfer of care is cultivating trust. That is, the new provider must earn the trust of the patient and family. A failure to do so will inevitably prevent an optimal transition of care. During transition, parents are transitioning along with their children. With transition to adult care, there is also a goal to transition responsibility for medical care from a parent or guardian to the patient or child. Setting goals and expectations can help both the parents and the child effectively make this transition. Now, transfer, on the other hand, as we said, is just the movement from a pediatric provider to an adult provider. This is typically from a pediatric cardiologist to an adult congenital cardiologist, but it may be from a pediatric to an adult heart transplant team, or possibly from a pediatric electrophysiology provider to an adult electrophysiology provider. Trust remains critically important in the transfer of care. You need to have trust in your pediatric provider about why it is they are recommending your transfer of care. Equally, you need to develop a relationship and trust with your new provider. Transfer does not mean that there are no more treatment options or therapies. Transfer just means that your care is now better served by an adult team as opposed to a pediatric team. Loss to follow-up is one of the most concerning complications of poor transfer of care. Based on a number of studies, there does not appear to be an association between the complexity of congenital heart disease and the likelihood for loss to follow-up. Some studies show as many as 40% of patients transferring care with congenital heart disease have a gap in care of at least 3 years, and this typically is occurring around the age of 20. Effective transition of care is essential for all severity levels of congenital heart disease. Transition is considered of such high importance that it was actually given the highest recommendation, a Class 1 recommendation, in the most recent edition of the Adult Congenital Heart Guidelines from the American Heart Association and the American College of Cardiology. As stated, all clinicians caring for patients with congenital heart disease should deliver developmentally appropriate transition education to adolescent and young adult patients with congenital heart disease and to their families and support network. This highlights why it's so important to be educated, prepared, and knowledgeable, so that when the time comes to make the leap from pediatric to adult care, you'll be ready. And you'll be able to successfully make that jump. So how do we do that? How do we make sure that we are ready for that big leap or that big transfer of care? We need to work with a team that can help us prepare for this eventual move. So let's talk about some of those issues and difficulties that patients and families, as well as providers, face leading up to this transfer of care. So the process of transition is complex, and there's honestly no one-size-fits-all approach to the effective transition of congenital heart patients. Each congenital heart patient faces different obstacles and issues, and the process of transition has to be addressed personally to them. Many patients live far away from congenital heart centers of excellence, and there are also currently too few adult congenital heart cardiologists trained in the care of adult congenital patients. Due to these challenges, there can be a significant amount of anxiety with regard to transferring care to an adult congenital provider or an adult subspecialty cardiology provider. This can be both from the perspective of the patient, the parents and guardians, as well as the pediatric cardiologist who would like to make the transfer. This time in a young person's life is not just a time of transition of medical care either. There are obviously many simultaneous life transitions going on as well. There can be a loss of focus on the importance of ongoing follow-up in medical care. So what topics should we address? What issues should we talk about? Providers should really focus on asking open-ended questions to assess the understanding of a patient's congenital heart disease, and then provide education as needed. Patients should be advised what specifically will be monitored with their heart and health going forward, as well as what future testing is to be expected. Counseling regarding medication adherence is a must, as well as guidance regarding insurance and medical coverage, and also highlighting the need for lifelong cardiology care. For our female patients, contraception and the safety of pregnancy should be addressed starting very early on. And identifying mental health barriers and other medical issues is also of great importance. And a question that we're asked most commonly is, what is the role of a parent or caregiver in this transition process? In other words, how can I help my child make this successful move? Parents play a vital role in the transition process. They are often the main source of a child's history and have been actively involved in their care from the very beginning. Providers should involve the parents in the transition process and should set goals and expectations. They should ask the parents to empower their child with regards to their medical care, such as encouraging them to manage their own medications, schedule their own medical appointments, and similar personal care needs. The medical team needs to practice patience when working with parents as well. This transition process is difficult and can be anxiety-provoking for parents and guardians. Providers need to acknowledge that parents have been the primary manager of their child's medical care for many years, and it's often difficult to give up this role or to hand over the reins. Remember, parents are transitioning just as their child is. So what are complications for failure of the transition? What are the main issues that we see? The worst possible outcome is loss to follow-up. This can result in potentially preventable medical complications. Inadequate or poor transition can lead to parental and patient distrust of their new medical team. Poor transition increases the risk of the patient also engaging in high-risk behaviors that can be harmful for their health. Patients who are not transitioned properly tend to utilize hospital resources much more frequently and often will seek care in emergency departments and urgent care settings, as opposed to seeing their primary cardiologist or their primary care physicians about their medical issues. I now want to take a moment and just to highlight how significant of an issue loss to follow-up is, especially here in the United States. A recent large study took a look at loss to follow-up and gaps in care for all congenital heart patients, not just here in the United States, but globally. They demonstrated that worldwide gaps in cardiac care and loss to follow-up for patients with congenital heart disease is seen in 26% of all patients globally. There are significant regional differences, though you'll notice, as over 1/3 of the patients followed in the United States have gaps in care or are lost to follow-up. This is really actually a very frightening statistic if you think about it, and shows just why it's so important to address the need for appropriate transition. The study further showed that regardless of the severity of congenital heart disease, there was high loss to follow-up rates. Here you see similar rates for loss to follow-up for all patients. 34% of patients with simple forms of congenital heart disease had major gaps in care or loss to follow-up, while around 26% of patients with moderate severity heart disease had gaps or loss to follow-up. Even the most complex patients, around 22% of them, were lost to follow-up or had significant gaps in care that impacted their overall health. Finally, we also see that centers that have a formal transition program, one that addresses these issues of transition and highlights the importance of an appropriate transfer, we see that the rates of loss to follow-up drop significantly compared to those centers where transition is not formally addressed. Although loss to follow-up for 12% of our patients is truly not acceptable, it is a much, much better rate than 36% loss to follow-up. This further goes to highlight the importance of having a dedicated transition team or a transition program to prevent loss to follow-up to avoid the major gaps in our patients' care. As parents, patients, and providers, we need to be mindful of the risk with loss to follow-up and gaps in care. And the potential to loss to follow-up is very, very real. And we all need to take an active role in preventing these gaps in care. I would encourage all parents and caregivers to recognize the importance of transition and encourage your children to learn about and own their health, and have them take an active role and participation in it from an early age. And what about our patients who are assigned female gender at birth? How is transition different for them? Well, in general, cardiologists are really not well trained in addressing issues such as sexual health and contraception. It's a topic that is not highly focused on during training in both adult or pediatric cardiology. However, discussions of family planning and the safety of pregnancy is important to begin during pediatric care. The longer that this is delayed, the higher the risk of unplanned pregnancy is in our high-risk patients. Discussion of topics such as sex and contraception needs to really be a routine part of visits for our adolescent and young adult patients with congenital heart disease. A way to overcome the discomfort or the awkwardness that some providers and patients feel with these conversations is talking about these topics on a routine basis and make it a normal conversation to have. The transition team can help with the resources and referrals to appropriate women's health providers as needed. There's a lot to be considered about women's health and the impact that heart disease has on a woman's medical decisions. We encourage that there be an open and honest collaborative conversation and approach to women's health issues. It's important that our female patients understand that their heart disease does not mean that they cannot become pregnant, and also that there are special considerations for their health regarding pursuing pregnancy and appropriate contraception options. So what are the key elements in the successful transition of care? Well, this has been well defined by the American Heart Association and their best practice guidelines, which our very own Karen Uzar co-authored. We are very fortunate to be involved in a robust research regarding transition care and congenital heart disease, and Karen has acted as an early leader and voice in this research. As these guidelines suggest, the transition process should really be formal in its organization. It should utilize surveys and transition tools and transition visits, as well as developing action plans and utilizing health passports to communicate information effectively to patients. Communication is really crucial, both between pediatric and adult providers, as well as between providers, patients, and their families. The transition and transfer of care needs to be specifically to an adult congenital heart provider or to an appropriate cardiology subspecialist. Many of our adult congenital heart patients end up under the care of general cardiologists, who often do not have the experience or expertise to effectively manage them. It has been repeatedly shown that patients with congenital heart disease who do not follow in adult congenital heart centers of excellence have worse outcomes compared to those who are followed. So now I'd like to briefly tell you about the Congenital Heart Center at the University of Michigan's efforts at addressing a transition and the wonderful transition program that's in place for our patients and their families. The transition program is coordinated by the Adult Congenital Heart Disease Program here at the University of Michigan and is led by our fantastic transition coordinators, Andrea Craven and Elizabeth Stalder. As our transition coordinators, Andrea and Elizabeth provide personalized education, preparation, and promotion of self-care for all of our adolescents and young adults with congenital heart disease. Through this program, you will receive individualized education about your heart condition, guidance about future potential complications and procedures, identify strategies for self-care, and this educational and skill building process acts as the backbone for a successful transition and eventual transfer of care. Our goal within the transition program is not to take over your care from your pediatric provider, but to provide additional support. Involvement in the transition program does not mean you leave your primary pediatric cardiologist. The transition coordinators will act as partners and augment the care that your primary pediatric cardiologist is providing. You will remain under the care of your primary pediatric cardiologist as long as you and they feel it is appropriate. The decision for transferring your care to an adult provider is very much a personal decision between you and your pediatric cardiologist. And there are many factors that go into determining when that optimal time for transfer of care occurs. Enrollment in the transition program will in no way determine when that transfer happens. A dedicated and personalized transition visit is a key element to providing the education and preparation that is needed for eventual transfer of care. During these transition visits, Andrea and Elizabeth will review many important topics regarding your heart health. Our goal is that all patients have at least 2 transition visits between the ages of 12 to 18 years of age, with one ideally being early on in adolescence and another occurring later in your teenage years. Additional visits may be scheduled as all patients require different support and education. Different topics that will be covered include details about your specific form of congenital heart disease and the history of your surgical and cardiac catheterizations. Elizabeth and Andrea will also discuss what it means to take an active role in your health, and it will also provide guidance about treatment and ways to seek attention for emergency medical situations. Andrea and Elizabeth will also talk about your future with congenital heart disease, and they'll highlight the importance of medication adherence and discuss what those medications are and what they mean. They'll also review the importance of nutrition and exercise, as well as addressing issues related to emotional and behavioral health. Another topic that they'll touch on is coping with life with congenital heart disease, and for our young female patients, again, talking about pregnancy and contraception. Many of our patients have questions about lifestyle, travel, and career considerations, and Elizabeth and Andrea will expertly discuss those as well. They are also able to provide specialty referrals as needed for issues that might arise outside of your cardiac health. These transition visits are encouraged to either occur in person or virtually, and they're available to all of our patients within the University of Michigan Congenital Heart Program. An intake survey is performed for all patients so that Andrea and Elizabeth can appropriately address knowledge gaps and concern for each individualized patient. We are also incredibly fortunate to have additional support within the transition program, including from our NCOPE team, the University of Michigan Congenital Heart Center's Psychosocial and Educational Program. Is a team that includes social workers, psychologists, child life, and educational specialists, as well as patient and peer mentors. Dr. Melissa Cusino leads our MCOPE team, and we are incredibly lucky to have a dedicated adolescent and young adult psychology fellow, Dr. Kelly Ray, who is dedicated to caring for our transitioning age patients. We fully recognize that emotional well-being is critical to both heart and family health. As such, Dr. Ray will be actually leading some special virtual wellness visits called the We Beat program for our transition age young adult patients. This unique webinar series is a free virtual wellness group for young adults with congenital heart disease to learn new skills to support well-being. Enrollment in this program will put you alongside other young adults with congenital heart disease and will allow you to engage in 4 virtual group sessions focusing on wellness, education, and additional learning skills such as relaxation, mindfulness, pursuing passions, and more. Please keep an eye out for updates as this will be starting later this spring. These are just some of the many ways the University of Michigan Congenital Heart Center is optimizing the transition of care for our patients. If you're interested in connecting with our team, please contact your primary cardiologist or call us. Please also keep an eye out as well for future We Beat Wellness sessions by Dr. Ray, as well as future webinar events for our transition age patients. Future web events do include 2 events already scheduled, one of which is Dr. Ray talking about mental health and wellness in May, and our very own Dr. Jesse Hansen, our congenital a pediatric cardiologist and congenital heart exercise specialist, who will be talking about exercise in August. I'm going to stop the formal portion of the presentation, but we would absolutely welcome any questions and comments, and would love to have Elizabeth and Andrea help me answer any questions.
Thanks, Dr. Joint. That was great. As he has said, my name is Elizabeth Stalder. I'm one of the nurse practitioners, and I'm one of the transition coordinators. We did get a lot of good questions here. The first one that I'll bring up is, what age do you think is the best time for a patient to transfer to adult care?
That's a great question. That's something that we get asked very frequently, and there's a lot of considerations that go into it. There are some patients and providers who prefer that their patients be transferred before maybe moving to college or starting a job. So typically around like age 18, towards the end of high school. Other providers really prefer to follow their patients through like college or the early portion of their 20s, because they feel that they want to kind of carry them through the other changes that occur in their life. I think it's really, again, a very personal conversation between a patient and their pediatric cardiologist. And it's something that also needs to be really effective for the patient and for the provider. Another thing that is not uncommon that we do, we are obviously at a large university. It's not infrequent that my colleagues and I will follow a patient who maybe is primarily followed in a pediatric cardiology or an adult congenital cardiology program somewhere else remotely in the country. But while the patient or student is here attending the University of Michigan, we can connect with them and act as a local connection. So there's a lot of different models and a lot of ways that you can kind of address care during that life transition and a major life event time. And so I think, again, it depends on each patient, but it's a conversation that I would encourage patients and families have early on with their pediatric cardiologist, so that everything's being addressed the way it needs to be.
Perfect. A question that kind of goes off of that. Another person put in, those patients who are going away for college, do you think it makes more sense to transfer care before they go to college?
Yeah, no, that's a good one. That's right in line with that last conversation. I think that I think it depends. I think that I think it depends on what a patient's personal kind of goals are, what they're planning on doing, and if they have an idea if they're going to stay local or go remote. I think that really, I think that it probably makes sense to make that transition or transfer of care, excuse me, after maybe going through college, unless they're going to stay local, and then making that transfer before then or around 18 to 20 years of age would make sense.
Another question we got was, why do I need to leave my pediatric cardiology provider? I like them, they know me best. Why would I want to leave them?
Yes. So another common, another common concern and question. And I think, as any parent, it's hard when our children grow up and are taken care of by a provider, particularly in the situation of pediatric cardiologies. Many times it's a provider that diagnosed their child's heart condition or got them through their major surgeries or early on major events. And it's very hard to say goodbye to that provider. And as a parent myself, I think that I don't look forward to the day of my children having to leave their pediatrician. But I think it's important to recognize that the pediatric cardiologists, though incredibly well-trained and knowledgeable, their comfort level is not with taking care of adults. And even though they are very comfortable with your congenital defect and congenital heart issues, they're not they haven't trained, and their focus and training has not been on the adult medical issues that you'll encounter with that form of congenital heart disease. So it just highlights the need to be with a team that's comfortable both with not only your heart condition, but also the adult medical issues you'll face.
This one was kind of a comment. They just said, thank you for recognizing the difficulty for parents in the process of transitioning. And then another comment, do you feel that insurance coverage plays a role in the loss to follow-up in numbers?
It's interesting. I think that you'd think that that was more of an issue than actually what it is. It's not actually as commonly due to that, mainly because of, especially with health coverage being assured for children on their parents' insurance into their mid-20s. That doesn't actually tend to become as much of an issue until our patients are actually into their late 20s or 30s. A lot of the loss to follow-up issues, I think, come due to confusion about the fact that their heart condition is repaired, or that they don't really need this follow-up anymore. I've been doing so well for so long. Why do I have to do this? And I think there's a certain sense of invincibility that is common in adolescence and teenage years that kind of extends to their cardiac care. And again, I think that just highlights the importance of why pediatric cardiologists and providers need to make sure patients recognize that they need that lifelong care and they need that follow-up.
Mhm. Another question we got was, can I attend the transition visits with my child? I would like to be involved in the conversations as well.
Yes, so understandably, that's a great question. I'm going to answer it, but I also want Andrea and I want you guys to weigh in too, as the people in the trenches doing the transition visits. But I think that in general, we obviously encourage parents to be involved, and we want them to definitely be very much a connection, because they've been the manager of their child's or patient's health right from the beginning, right from the get-go. But I think one of the key steps about the transition is actually the first, maybe they're baby steps or maybe they're gigantic leaps, where you're extending that space for your child or for the patient to really take on their health. And it's important that they do that partially on their own. And oftentimes, I won't speak for you guys, I'll let you two, Andrea and Elizabeth, comment, but it's not that we discourage you for being a part of it, but there definitely will be, if not the majority of the transition visit, a large part of it, where we need to speak directly to the parent or to the patient, excuse me, without a parent or guardian there, because I think it makes this process real. And it can feel like, oh, at 13 or 14, they're too young to do this on their own. I would agree. A 13 or 14-year-old is a little bit early in taking on all of this care on their own. But I do think being able to be a part of a conversation on their own with a provider, talking about things like, what's your diagnosis? Why do you take these medications? I think it puts them on a spot, and it puts them on the spot in a healthy way, in a nurturing environment where we can help kind of figure out what things we need to do to help prepare them for the eventual big jump, big leap. I don't know. What do you guys think? I'll welcome your take, Andrea and Elizabeth.
When we meet patients in clinic, telling them about the clinic, we always talk to the patient and the family members to say that this is both, it is patient oriented, but we welcome family members to be involved in these visits. And during the visits too, there is a time period where if we are in person, doing the visits in person, or if we're doing them virtually, we will ask to just, speak with the patient and just kind of connect to them without their parents, to talk about anything that maybe they don't want to discuss with their parents. So we do welcome parents. We encourage them to come because they 100%, we want them to be involved in this process. But there is some individualization of just speaking with the patient during the visits.
And it's so awesome when you can see everything clicking together. I feel like in our younger patients, where they come in not having any idea what their diagnosis is at all, and you're asking open-ended questions, then by the end of the visit, they can name off their diagnosis, their medications, and you can see the empowerment in the patient. So I think a lot of times we've had family come in and they think the patient knows all this, and then when we ask the open-ended questions, they don't, and the parents sometimes are surprised. And I think it's because they rely on the parents so much. So I think that's a part of this, is just we have this kind of open conversation, just where are they at in the process of what do they know about their heart disease. So I love having parents come, because I think it's eye-opening for them as well, because they kind of understand, wow, I thought you knew all this. We talk about this all the time, but when you put them on the spot and actually ask them, do you know this? A lot of times they don't. So that's where Andrea and I come in. So it's awesome actually to see someone at the end of a visit really understand and have that power, their knowledge now.
Totally. And I think there's an element too, sometimes the majority of time, the majority of the times where you start asking or talking about the things that, quite frankly, parents sometimes don't know how to answer. I don't, how do you answer what this means or that means because of your heart disease? There's a sense of so much relief from the parents to be like, oh my gosh, I'm so happy somebody's talking to me or talking to my child about these issues that we worry about day to day. And it's nothing against the pediatric cardiology providers, but when you focus on here's the results of your echo, or here's when your next catheterization or surgery is, or things like that, those day-to-day questions of things like, what job can I do? What should I avoid doing? Is it okay for me to play this sport or that sport? Like, those don't always get addressed as easily and fully, and that's where those transition visits can be profoundly helpful.
Here's a question I wanted to bring up. So they said, how many visits with an adult provider do you think are needed to build that trust before transfer, given the patient family long history?
So that's a great, that also comes up quite a bit. And I'll answer that a couple of ways. So the University of Michigan, we're very lucky in that our pediatric and adult congenital cardiology teams are really like embedded together. I mean, physically, my office and the offices of my colleagues are within the Congenital Heart Center, and we also see pediatric patients in addition to our adult patients. So we have a very close working relationship with obviously our colleagues and our pediatric cardiologists, and I think that helps in terms of how we can kind of recognize what patients and families go through on the pediatric side, as I am taking care of pediatric patients on the pediatric side as well. So I think that helps immensely. I think the trust question is a great one, and I think every patient will feel differently about that. And I think much of it is set in the tone of that accepting provider on the adult side. I think having providers that are knowledgeable about your heart condition, knowledgeable of the care you were receiving before, from whom, and to also recognize, and something that I can speak for myself, and I would go and say I speak for my colleagues, we are very much into collaborative care. And so if something is coming up or something, an issue comes up with a patient that maybe one of our pediatric cardiology providers, a patient that they used to see, we'll discuss it with them. We'll bring it up to them and we'll let them know. And I think that collaborative care model really helps to improve that trust. And it can be pretty quick that you can develop that sense of trust, often in the first visit or two.
This was a question, what efforts are being made to increase the number of ACHD providers?
Right, yes. So, a lot. There's an intense focus, as a matter of fact, on the number of adult congenital providers. I know Andrea and Elizabeth are both, we feel it. We are with you. There should be it's like a 5-alarm bell or something going off to get more adult congenital providers, because the numbers aren't actually even close. There are way more, like over 2 times as many adults with congenital heart disease compared to children with congenital heart disease. And nationally speaking, there is a marked shortage in the number of adult congenital providers, both physicians, nurse practitioners, mid-level providers across the board. There's definitely actually a survey just recently came out from one of my colleagues seeking out input from pediatric fellows, pediatric and adult fellows in cardiology, and trying to find out why there is not more interest, or why more people aren't going into it. I think the training is long. Most of the people who do adult congenital cardiology has spent, typically it's actually a 4-year residency instead of just a 3, because many of them are internal medicine and pediatric trained, as am I and all of our colleagues here at the University of Michigan. But then there's a 3-year fellowship in either general adult cardiology or general pediatric cardiology, then another 2-year fellowship after that. So you're talking, many of these people are taking a 9-year road to get to the end of their training. That's a long time. And so there's definitely efforts to try to increase that, but it's not quick. And as you note, as pointing out, if it's a 9-year Hall, even getting people who are in the medical school side of their life interested, it's going to be a decade before you see those results down the road. So there's definitely an effort to address this and increase it. We're incredibly fortunate at the University of Michigan. We have currently 3 adult congenital cardiologists. We're actively in the process of hiring a 4th, and we have 2 wonderful nurse practitioners and a great support team. But I do feel for our patients who are in areas that don't have those resources as readily available.
I wanted to bring this question up because this is one that we've gotten actually from pediatric cardiologists we've been working with. What do you recommend for patients with developmental delays? My son is trisomy 21, and I'm not sure how he'll be able to participate in transition visits.
Great. Yeah, no, that's a great question too. There's a lot of concerns for parents with children with a variety of developmental delays. And the process of transfer is, just as important, if not sometimes more important when considering that and figuring out a good team to accept that patient and who's going to develop that trust and be able to take care of a child or a young adult with developmental delays. We typically, for those visits, and I also encourage you, Elizabeth and Andrea, to comment, those visits are certainly different from the traditional transition visit if patients are not as able to actively engage in some of those active or those questions and open-ended discussions. We still, however, recommend doing kind of more transfer dedicated visits. And many times parents will have questions about considerations about life and career, insurance things, guardianship, and questions about that. Those topics are just as equally important to address. And for those conversations, though, that would certainly have the parent or guardian involved in talking about it. And also, we need to be able to address the concerns that they have, what this means for them as well. Again, for parent or guardian, they are making that transition and transfer process just as well. And the parents and guardian have to figure that out probably more so because it's not unlikely to be a situation where they're looking to extend that managing of the medical health issues to the patient, but looking to kind of appropriately address those issues in an adult realm, which is a whole new ballgame compared to growing up in a pediatric world.
Yeah, I think that answered that great. We've already done some transition patients, our visits with patients who've had some developmental delays, and I still found that it was very helpful for the patients, but particularly the families. As you said, it's a big transition when they become an adult, talking about guardianship, even just going to the adult ER versus, the pediatric ER. So I do find it's very helpful. Andrea and I definitely, frame the visit differently. We kind of approach it and ask different questions and kind of meet the person and the patient where they're at, but still incredibly helpful.
Yeah, and I think another thing too that comes up related to that, not just like physically, where do you go in terms of, as you pointed out, like what emergency department, what should I do or where should I go? We also are lucky at the University of Michigan to have some resources where patients can have actually kind of like, instead of child life specialists, adult life specialists, so to speak, and family life specialists who can help kind of focus on, this is where the CVC is, or the cardiovascular center, or this is even where you park and where you go in and what you do. Those questions, even though they seem trivial, are wildly important. I mean, that really can extend a lot of anxiety to families if they don't know where they're going, what they're supposed to do, who they're supposed to connect with. And we recognize that, and we need to address those issues, not just for our developmentally delayed patients and their families, but for all of our families who are making this transfer of care.
And then I think I have one last question here, unless anyone else pops one in. They just asked if there are any websites or educational materials you'd recommend for career exploration considerations with people with congenital heart disease, especially for maybe those with implanted devices.
So there are some great resources available online. One of the best I would recommend to look at is the Adult Congenital Heart Association. I'm trying to think in my mind if there's any specific things about career and life things, which are work things, which I'm pretty sure there are. I haven't checked recently, but if I remember correctly, there are. I think also sitting down, and again, this is where the transition, like Elizabeth and Andrew, can be very helpful. It really depends a whole lot on what type of, what you have, what type of device you have and things like that. And considerations related to it. And also having that conversation openly with your, in that case, an electrophysiology provider or your subspecialty provider. And again, if this was heart failure transplant or an electrophysiology, is your primary cardiology team or pulmonary hypertension. All of these teams have a great amount of knowledge and expertise and are also equally focused on transition. Sometimes it takes just, writing these questions down and bringing them up and saying, I'd really like to address this and talk about this in kind of a transition format.
And then we actually just got some couple really good questions.
Right.
Regarding the ER, should your young adult congenital patient go to the pediatric ER or the adult ER?
Great question. It also depends. Institutions are very different, but I can answer for the University of Michigan. So at Mott and at the adult hospital at the University of Michigan, there's a lot of kind of interesting rules and thoughts that go into that. So the pediatric the pediatric emergency department can indeed see patients up to like 21, 22, but typically, one of the recommendations that will be made both by our transition coordinators and by your pediatric cardiologist or your adult congenital cardiologist is to kind of review those exact things. Where should I be taken care of? What if I have a medical emergency? Where should I go? Just because you have congenital heart disease does not mean you have to be in the pediatric hospital. We actually take care of many of our congenital heart patients over in the main hospital who are well into their 20s, 30s, 40s, 50s, and 60s. So many of our patients with congenital heart disease are taken care of in the emergency department and the adult side and in the adult hospital. One of the benefits of having a medical center that is so connected like the University of Michigan is our providers, pediatric or adult congenital providers, can easily see patients in the adult side or in the pediatric side. And so that's very helpful. You'll also notice at the Congenital Heart Center at Michigan, some of our patients who undergo like a heart surgery for their congenital defect may be taken care of over at Mott, or they may be taken care of over at the CVC or the Cardiovascular Center or adult hospital. It's really a conversation about what care you need and what services would best serve you for the issues that you're facing. So it's a complex question, and it's something that is important to review both either with your transition coordinators or transition team or with your primary cardiologist.
Yeah, I feel like it's all about collaboration between MOTS and the CVC with us. A question that kind of goes along with that, while transitioning from pediatric to adult, does your child see their adult cardiologist in the pediatric building or the adult?
Great question. So it depends as well. So the majority of our adult congenital patients are frequently seen at the cardiovascular center, but not all of them are. We will still see some of our adult congenital patients over here at Mott. As mentioned before, not only myself, I do outreach at our Michigan West office, which is a pediatric cardiology office, but both of my colleagues do outreach to pediatric cardiology offices also across the state. So I also go up to the Brighton Subspecialty Center where I see both pediatric and adult patients. So to be frank with you, we can see patients in a variety of settings. Sometimes it's just space and where we can get a patient in to be seen that kind of dictates where they end up going or what location we see them at. But just because you're seeing, for example, one of us as an adult congenital provider doesn't mean that it has to be over at the adult hospital or in the pediatric hospital. One thing I would caution with that, though, is that as you transition into adult care, that model won't be followed in all settings. In other words, once you reach a certain age, typically it's 18 to 21, depending, if you need to see, for example, a gastroenterologist, they are going to ask that you be seen in the adult hospital because that's where they see their adult patients. Same thing with other subspecialty areas. The cardiology with involvement from adult congenital cardiology, we have a lot more flex and a lot more ability to kind of make the system work to a way that's most effective for our patients. but other subspecialties might be a little more rigid. So that's an expectation I like to share with our patients, because that's not extended to all subspecialties.
This question was, are the adult cardiologists comfortable with the treatment plan for their young adult congenital heart patients, as oftentimes their heart health can become more compromised as they get older? I would almost say this is why you need the adult congenital cardiologist, but I'll let you answer there, Dr. Joy.
Yeah, no, I would agree, Elizabeth. And I think, yes. So what you'll find, all of the adult congenital cardiologists are trained and knowledgeable in congenital heart disease. So they have a similar, if not identical, training to your pediatric cardiology providers. The way I would look at it is they also have additional training in the care of adults. And I think I would echo exactly what Elizabeth said. The main issues that start to come up are, yes, complications related to your heart disease certainly come up and are certainly seen in both the pediatric and adult realm. And that's why you need a cardiologist who's knowledgeable in congenital heart disease and not a general adult cardiologist. But the other things that really end up complicating your overall health are non-cardiac issues. So I would say a great example is like pregnancy. Many of our colleagues in pediatric cardiology will come and seek our input as adult congenital cardiologists if one of their younger patients becomes pregnant, because they don't have as much experience with it. That's not a comment about knowledge or an insult or anything. That's truly just kind of experience-based. And so issues like that come up in adulthood, we certainly see far more frequently, and I think have a much more level of expertise and comfort with managing it.
So I think that was all of our questions. I'm going to give it back to Dr. Joint to kind of close us out today.
Well, thank you. That was a great discussion. Thank you, everybody, for attending. And as mentioned before, we'll make sure that this is up on our website. And please, as it's kind of been rolling through there, the information is on the screen about how to contact us to get connected with the transition program. And also, please stay tuned for future webinars that I think are going to be very informative. So thank you, everybody. Greatly appreciate it. Have a good night.